All right, whoa, this is very noisy. Can you guys let me know if that doesn't work? Okay, how about that? Oh dear. Okay, we might have to try that without the microphone. I'm not really good with the microphone, so if I speak loud enough, is anybody can hear me, or should we, you guys in the back, let me know if you can't hear anything, and I will put the microphone back on. I do have one microphone for the online group, so I got the okay that I can get started. Very warm welcome. I'm very pleased to see so many people here. That's wonderful. And also a big welcome to everybody who's watching online and didn't make the drive. It's totally nice to be able to watch this one with a glass of wine, which I would like to have too, but we'll get through it. Anyway, it's very nice to see all this interest in pain. There is a lot of pain stuff out there, and I find it very confusing sometimes to figure it all out. So let's kind of try to go through some of those things about pain. Unfortunately, I think for understanding pain really, or all the drugs we're using, we're gonna have to go through the pain physiology and pathophysiology. So bear with me while we go through that, but I think when you're trying to understand why tramadol may or may not really work for acute pain, let's see, where does it actually work? So if we go through the pain pathway in a very simplistic way, please ask questions if you don't quite can follow me, and then we can go through some of the, we'll focus on acute pain because we'll do an anesthesia talk, what we can do during anesthesia, as well as how we can kind of handle the immediate post-op care. If we're going to go into chronic pain, we probably cannot do that for another couple hours because it's such a big topic. So right at this one, we can totally answer some questions about chronic pain, but in general, we're going to go through the post-op acute pain to go through it. So we're going to go understanding the pain pathway, as well as then going through that, and then just going through some discussions. So pain in general is a good thing. You cannot live without feeling pain. And we know that from, children with congenital insensitivity to pain syndromes, they do not make it usually past the age of 6. They usually hurt themselves so badly that they don't make it. So pain in general is a very good thing. This is a very impressive movie about a child that goes through this one and the challenges with the parents. So it is protective. You want to be able to feel that there's something noxious and threatening, and you want to be able to withdraw from it. So in general, pain is not a bad thing, but surgical pain, not really that protective. It might be still physiologic, but it's not really a good pain in that sense, right? And if we kind of not treat any surgical pain, and we still always, when we looked at the old school thinking that, especially when we looked at horses, don't treat the pain that way, they don't move the leg as much and don't use it as much. We kind of are off that, fortunately, because when we kind of understand if we do have pain that is not treated, or when you have chronic ongoing pain, you have delayed wound healing, and you have a slow recovery. You want them to recover quickly from that painful stimulus and get out and be back to normal. You have a huge change in your homeostasis, which is due to neuroendocrine situations and sympathetic tone, which can lead to internal complications. Anything, it's a continuum for the pain. Anything from acute can turn easily into chronic, and we'll go through it, and you'll understand at the end of it why. Definitely can change the behavior. We always go well, that cat is crazy painful, and it is gonna try to bite your head off, or it's gonna scratch you. We know aggression, depression comes from pain, so we want to try to not get into that. So it's very deleterious to the patient. And I realize this is a very busy slide, but just kind of see what pain can do. And pain is a disease, and a disease needs to be treated. So if you have, and the thing what I highlighted is that neuroendocrine changes that you have that causes immunosuppression and decrease in wound healing, the sympathetic tone, you have a high heart rate, a high blood pressure, the high respiratory rate, everything is high, lots of catecholamines going around, and you know what that can do to your kidneys, as well as to your blood flow, right? And then the other thing is the behavior stuff. Yes, we always contribute that to the human ones. We know that everybody who has pain often ends up having depression too. So if you can have that demoralization, any problems with like sleeping, you're gonna have behavior changes and changes in the CNS. It'll be a bit harder to figure that out in animals, but some extrapolation from the human knowledge is definitely important. So there's a lot of things that are happening with pain. So another reason from an ethical and moral standpoint of view, we treat any other disease, we do need to treat pain. It is just a little bit harder to do because it's not just a black and white antibiotics, yes or no kind of situation, because we don't understand it. The problem really is we don't understand it. We know some parts of it, but only some parts, not the whole story, especially if it comes to chronic pain, because the CNS changes so much with the constant triggering of any pain neurotransmitter. It's constantly unfolding, so we're figuring things more and more out. There's a lot of research coming out because chronic pain in North America is pretty much the #1 demoralizing problem for humans. So lots of research is going in that direction. And probably, unfortunately, especially in veterinary medicine, there's no evidence, like no evidence for anything, because we can't assess pain in animals very well. We have all sorts of scales and weird methods, but we don't have a golden standard to say, I'm going to use this one to figure out if this is animal painful. So you can tell me, yes, this or this might work or not work, and we're trying to understand why it may work or not work, but we have no evidence in it at all. We're just trying to understand it. So let's go back to that whole physiology. So the regular system, right? You're touching something hot, you're withdrawing before it even goes to the brain. That's your normal motor reflex. But whenever that happens, it goes to the dorsal horn. That's where things are decided if it's going to go to the brain or not. So, and that's going to be the part that goes from the spinal cord into the dorsal horn. So when you look at the pain pathway, we have 6 different types. We have the transduction, that means we get a noxious stimulus. It always gets sent to the dorsal horn, which is the transmission. We have the modulation, where things get kind of like either upregulated or downregulated, excited. Do you have like an increase of an effect or a decrease in effect? That's where things happening. The projection to the brain, and then the CNS kind of saying, okay, I feel a pain. I feel a pain. And then the descending pathway that, again, which is very important for chronic situations, and that's where, for example, drugs like tramadol work, is going back to the dorsal horn and saying, okay, there's more to it. Let's up or down again. So that's kind of a circle that keeps going. We want to kind of remember, like, yes, under anesthesia, we put that perception away, right? So we can anesthetize anything deep enough that you don't feel the pain. But all that pain, nociception, that pain pathway that goes all the way up to the perception, is still going to happen. So once you stop the anesthesia, all that is totally upregulated and painful. So you really want to treat anything before it happens to the brain. So that's one of the big things that always come back, the difference between nociception and pain. So pain is actually being awake, realizing something is painful in your body. Nociception is all that neurology, that physiology that's happening before you even realize it. So there's a wonderful book, Pain Management in Veterinary Practice. It just came out. I don't have any part of it, but I'm still advertising it because it is very complete for acute chronic pain, and it explains the physiology very well. So it's kind of what I just said about, like, just in different words, and everybody likes different words. If it comes to neuro seems to be like this, the words are too fancy. So you kind of like just that, again, the pain that gets kind of like recognized in the periphery, sent to the dorsal horn, and that's where it gets modulated, changed up, and sent to the brain. And that's your regular pain pathway that's usually happening. And we'll go through some of that in more detail, just for understanding with thinking, where do the drugs work? So bear with me through that. So we're trying to go through each one of those steps, and always kind of keep in mind, this is where these different drugs work. All right, so the first one is the transduction, right? That's where the nociceptors in the periphery, wherever they all are, detect some sort of noxious stimulus. And the noxious stimulus is a stimulus that has a strong enough intensity to either threaten or cause any tissue damage. So it can be either mechanical, chemical, or thermal. Those ones are the different, usually, stimulus that cause any nociceptors to be activated. Nociceptors are like just peripheral nerve fibers, usually. So they have the dorsal, they have a dorsal horn ganglion. They have the periphery that picks up the information. And then the central axon that goes into the spinal cord. So that's all there is to. There's a bunch of those ones around that go into the periphery. And just over there, these nerve fibers in general, there's two different types. And you've learned that in school a long time ago, that we have the A delta fiber and the C fibers. The A delta fibers are the myelinated ones. They kind of transmit that pain really fast to the dorsal horn, so you get it really fast in the brain saying, wow, that was a sharp pain. It's really painful, and so you can kind of see it has the big loop there, and I totally can localize where that's happening. The C fibers, they're not myelinated, so they transmit a little bit slower. So that's a kind of that dull pain that's coming from that somewhat direction, somewhere there. Can't really pinpoint it. And that's kind of part of the chronic pain. The one we don't want to forget is the A beta fibers. So they're just in charge of touch. They're actually noxious. So, but they look very similar, right? Like, so they're bigger fibers. They're very myelinated too. So they have a fast response. But they're going to come back later when you kind of think about pain that, you know, when you start rubbing it, they are the A beta fibers that kind of take the pain away a little bit for a short time at least. So those ones, keep those ones in mind for later. So the endings of those fibers, they have like some sort of them, all sorts of receptors on it. And you do not need to remember them. Just keep in mind that, you know, when you look at serotonin receptors, sodium channels, so those are kind of things where some of the drugs are working. Am I in your way or can you guys see? You good? Okay. But in general, the end of the nerve fibers are just sodium channels. So anytime there's a stimulus, it activates those channels. They open up if that stimulus is strong enough, and then you have an action potential, a depolarization, and the action potential is going to be sent up that nerve fiber up to the dorsal horn. So look at that picture, right? So you have mainly the turquoise one, the sodium channels happening everywhere. It's all just the action potential sending up by sodium channels by kind of like sending things up. So the drug that works there is lidocaine or any local anesthetic, and you can block anything going up there, right? So those ones, so that's why the local blocks are fantastic. Anything of that pain pathway, not even happening because you block it if you do your block right. But they only block it during the time the block is working. So if you have lidocaine, for example, it lasts about an hour or 2 hours. Bupivacaine lasts about 3 to 4 hours, right? So during that time, nothing is happening. But on the other side, you can't just rely on those ones because you're still going to cause the injury here. As soon as the block is wearing off, you start sending things up again, right? So you still want to do some sort of other analgesia. But if you're doing the time, like for example, the dental blocks, right? While you're kind of like trying to clean and pulling teeth, you don't have to keep them that deep. You don't have to provide so much other analgesia if you're able to block things off in the meantime. And then you just have to get the timing right, how long it works. Does that make sense? So then the fibers, these nerve fibers, the A delta and the C and the A beta, they go to the dorsal horn. And it doesn't really matter which lamina they go to, but when you look at it, like these fibers, they kind of like link to interneurons. Those ones are these kind of crazy things that are sitting there. And that happens like by all sorts of different receptors. So they activate those receptors and neurotransmitters are going to be released. And then either that pain signal, depending on the neurotransmitters, are going to be upregulated, intensified, or inhibited. And then they're going to get sent to the brain. So the main neurotransmitter in this area are like the GABA, GABA, glutamate, and the substance P, right? So those are very important neurotransmitters. So the